Thank you, Daniel. Thank you, Mr. Chairman. So I will focus my talk on blood transfusion and especially in trauma patient and in hemorrhagic shock in trauma patient. So we know that before controlling the bleeding in a trauma patient, we have to be concerned about the fact that we have to prevent an increase of the bleeding. And so we apply this, we perform this by a damage control resuscitation strategy. So we try to not give too much fluid, so a low volume fluid resuscitation, and we try to tolerate permissive hypotension to prevent dilution and hypothermia and deterioration of the coagulation. It's also important to consider that we have an aggressive strategy concerning the restoration of coagulation, so an aggressive transfusion strategy. So the concept of the damage control resuscitation is, as I told you, to limit the quantity of fluid and to tolerate permissive hypotension. And so we try to have to respect a target of systolic arterial pressure between 80 and 90 millimeters of mercury until the bleeding is stopped. And if we have to deal with an associated trauma brain injury, we increase the mean arterial pressure to increase the cerebral perfusion pressure. So what is recommended is to use first isotonic crystalloid and to restrict colloid. And very quickly, if we have no response in terms of arterial pressure, we add to fluid resuscitation, we add vasopressor to maintain arterial pressure within the target. So when we apply this strategy, so reducing the volume resuscitation and be very aggressive on the coagulation, very aggressive on the transfusion, clearly during the past 10 years, we have clearly a change of a shift toward a reduction of the crystalloid volume and an increase of blood transfusion, an increase of FFP. And it's clear in this slide. You can see it's in a trauma, in a US trauma center. You can see how we observe a dramatic decrease in the quantity of crystalloid, and we have an increase in the number of red blood cells transfused and the number of FFP. Just to highlight this point, it's a study where it's a pilot study where they try to apply a control resuscitation strategy where they try to control the fluid that they give to patient. And as you can see, they give 250 milliliters of fluid if there are no radial pulse or if they have a systolic arterial pressure lower than 70 millimeters of mercury, and then they give additional bolus to maintain a radial pulse or to maintain a systolic blood pressure higher than 70 millimeters of mercury. And they compare this control resuscitation group to a standard resuscitation group. And you can see that by doing this, they can decrease the quantity of liquid that they give patient. It was around less than around 1 liter less in the control resuscitation group. But what was interesting in this study is that if in the control group you look at the quantity of crystalloid, you can see that you have a very small amount of crystalloid. But if you look at the total fluid in the two groups, at the end, it was the same. And it was the same because when you look at the blood product, they compensate by giving more blood products. So clearly, now we give less crystalloid, and by being very aggressive in transfusion, we give more and more blood to our patients. So what is important is also if we want to be very aggressive concerning restoration of coagulation, we have to monitor the coagulation at the bedside of the patient. So in addition to the traditional laboratory determination, more and more we use technique like viscoelastic method, which give us very quickly, less than 50 minutes, result at the bedside of the patient. And by this way, we can have really a goal-directed strategy concerning our blood transfusion. So what is also important is to establish protocol in your unit and to define packs of, with a specific ratio of red blood cells, FFP, and platelets. So here is, for example, is a protocol in the Royal London Hospital. So it's important to have a clear clinical index to alert and declare red code. So here it's a systolic blood pressure lower than 90 millimeters of mercury. And other very important clinical index is the poor response to the initial fluid resuscitation. And you have to, in your protocol, to be able to give immediately red blood cells. And the best is that when you get the call that a patient will arrive in your trauma center, you have to order red blood cells, O-negative red blood cells, and to be able to give red blood cells immediately when the patient arrived in the emergency room. And it's very important also to think about the blood delivery, and because it's important to have quickly blood products and not to wait for them. So this has to be established in your institution, and it's very important to work with your blood bank to make this very smooth. So just to illustrate the thromboelastography, so it's now it's become more and more easy to obtain very quickly this result, and you can, depending on the result, you can know if you have to give more FFP or if you have to give more fibrinogen or platelets. So I think that it is now very useful tools to monitor the coagulation of your patient. So what is the good ratio between FFP and red blood cells? This very famous study, it's the Holcomb study, where they compare two ratios of FFP and red blood cells, a ratio where they give plasma, platelet, and red blood cells in a 1-1-1 ratio, and they compare this to a 1-1-2 strategy. And you can see that in terms of mortality, there is no difference between these two strategies. But the problem in this study, or a remark which is very important to do, is that in the 1-1-1 group, they give in the first set of transfusion, they give a dose of platelet. And it was not the case in the 1-1-2 group, where they give this dose of platelet only during the second pack of transfusion. So maybe there is also a role of platelet in the results that they observe. So no effect on the mortality. But if you look at a secondary endpoint, which was the capability to stop the bleeding and to do the hemostasis, in the group 1-1-1, it was more efficient. So I think it's a plus for this group, but we have to keep in mind that it's a secondary endpoint. So it's a limit of the result of this study, and the only result that we can theoretically consider is the fact that there is no difference in mortality and that the two strategies are equivalent. Is it the same when we have to deal with patients with no trauma? For example, in hemorrhagic shock after surgery, a recent retrospective study which consider massive transfusion, and they look at the different ratio. They look at a high ratio, it was 1:1, or a medium ratio, it was 1:1.4, or a low ratio, it was 1:3. And you can see that globally they observe no difference in mortality. So maybe when we have to deal with patients without trauma, maybe the ratio will not be the same. So we need more study to establish this, but you can see that for vascular surgery, a high ratio seems okay, but for medicine patient, a low ratio seems to do well. So clearly, we need more study. So what about fibrinogen? And fibrinogen is, we have to guide this with, once again, a viscoelastic method, and it is recommended to give plasma fibrinogen when we have a level lower than 1.5. And it is suggests that we initially, when we have to face to a massive hemorrhage, to initially give fibrinogen, to give 3 to 4 grams of fibrinogen. But it's some team, especially in Germany, or a team from Austria, try to manage their massive hemorrhage without FFP. And they manage this by giving blood product and given red blood cells and fibrinogen. Only this. And to guide their, once again, the hemostasis using the thromboelastography. And you can see that in this study, even if this study has several limitations, but it's interesting to consider this kind of strategy. You can see that by not given FFP, they can have a positive effect on sepsis and on multiple organ failure. There is an ongoing study, and I saw the result in a Brussels meeting. So this kind of strategy is maybe in the future interesting to consider. When we look at the European guidelines in terms of management of major bleeding, clearly now what is recommended is two strategies. The classical strategy where we give, in addition to red blood cell, FFP in a plasma red blood cell ratio of at least 1:2, and or a second strategy where they give, we can give fibrinogen concentrate and red blood cells according to the hemoglobin level. But I think that in this second strategy, we need more study to establish this strategy. So maybe in the future also it will be interesting to consider other plasma, and especially dry plasma. And there is also ongoing study testing these products. So another important point in my mind is that sometimes it's very difficult to know what is the good target of hemoglobin when we give to our patient red blood cells, and especially it's difficult to know if we give enough red blood cells to have a good microvascular circulation. And just we perform a study in hemorrhagic shock. We look at the effect of 1 unit of red blood cells, 250 millimeters of red blood cells. At the level of microcirculation, we look at the microcirculation with a camera looking under the tongue, the microcirculation. And you can see that in this patient, we give red blood cells, but if I look at the systemic hemoglobin, it was okay because it was 8.5, but the physician thinks that he had to give red blood cell to anticipate considering the bleeding. And you can see that even if the systemic hemoglobin level was okay, at the level of microcirculation, in some patients, the microcirculation was clearly altered. And when we give 1 unit of red blood cells, it's not a lot, we can see in most of the patients a very nice improvement of the microcirculation. So maybe it's a question, and maybe we have to not exclusively focus on the hemoglobin concentration as a transfusion trigger, and clearly we need more tool to analyze microcirculation and to know what is the optimal hemoglobin level for microcirculation. So in conclusion, it's clear that in a trauma patient during the last 10 years, we observe a very aggressive strategy concerning transfusion, and it's clear that we give more and more red blood cells, and we try to establish as quick as possible, to restore as quick as possible the coagulation of our patient. Thanks a lot.